investigating the lack of surgical performance feedback for surgeons after postgraduate training and the potential of surgical coaching. A dissertation final defense by Kevin Phung. Feedback is an indispensable component of one's journey towards achieving expert performance, but routine feedback from peers is rarely utilized in the field of surgery. This is most famously highlighted by Dr. Atul Gawande in his piece in the New Yorker, stating, "Top athletes and singers have coaches. Should you?" And the article goes on to speak about how no matter how well trained a person is, few can sustain their best performance on their own. And that's where coaching comes into play. In a review of the literature, we look at Erickson's theory of acquisition of expert performance using deliberate practice. And deliberate practice incorporates feedback, reflection, and intentional adjustments in order to reach expert performance. Without that, performers can hit a state of arrested development in which their skills do not increase in performance despite an increase in experience. And this is exactly what happens in the acquisition of surgical expertise amongst surgeons. Now, after surgeons finish their surgical training, either through residency or an additional fellowship afterwards, they go into independent practice where there is little to no meaningful feedback after training. And because of this, they reach a plateau or a stage of arrested development in their expertise. Whereas the expectation is for them to increase their expertise and innovation with time. But what is missing here is the feedback. And this matters because out in the workforce, there's a wide range of skill amongst surgeons in practice, with the least skilled surgeons having the highest rates of postoperative complications and highest mortality. And this comes at a big cost, specifically the cost of human life. And the Institute of Medicine estimates that approximately 100,000 people die in the United States due to medical error and preventable adverse events. And these poor outcomes from surgeons that are not performing at the highest level are contributing to this number. Now, this study's conceptual framework adapts Bandura's social cognitive theory, which depicts the model of triadic reciprocity between person, behavior, and environment. Now, the purpose of this study is to understand the experiences, attitudes, beliefs, and perceptions of OBGYN surgeons who have participated in surgical coaching. Also to identify the perceived environmental and structural factors acting as barriers to feedback. Research question number 1. What are the common attitudes and beliefs shared amongst surgeons who participate in a surgical coaching program? Number 2. What environmental or structural factors are viewed by surgeons involved in surgical coaching as barriers to the provision of individualized surgical performance feedback after postgraduate training? Number 3. What is the perceived impact of surgical coaching on a surgeon's behavior and cognitive processes? This is a qualitative study with semi-structured interviews interviewing 9 academic OBGYN surgeons with experience with surgical coaching, either as a coach, coachee, or both. For data collection analysis, data was recorded and transcribed in Zoom. Atlas TI was used for coding, and a USC secure ChatGPT was used to confirm thematic analysis was thorough, and it seemed to be. For findings on research question 1, which was looking at attitudes and beliefs, surgeons were found to be intrinsically motivated to improve, holding lifelong learning and a growth mindset. There was also a belief that that newly graduated surgeons were not prepared for independent practice. They lacked confidence and did not feel ready to operate independently upon graduation. Findings for research question number 2, which looked at environmental barriers to feedback. Participants talked about how there's a lack of feedback infrastructure after surgical training, quoting that there's nothing, Peer review was found to have inadequate feedback due to its untimeliness and non-specific nature of feedback. Time was also a constraint, competing with productivity. Everyone was busy, but also coaching itself is unpaid labor. So by uh, dedicating time to coaching, that meant less productivity, which meant less money and compensation for the surgeon. Lastly, surgical culture was found to stigmatize vulnerability and deter feedback seeking behavior because asking for help was seen as weakness and incompetence. Lastly, research question 3, the impact of surgical coaching on behavior and cognition. One major finding was the improved self-regulation of the participants, especially in the setting of goal setting and reflective practice. There was also increased self-efficacy amongst the participants that um, were involved with surgical coaching. And lastly, an improved and transformed way of teaching using coaching principles. Recommendations for practice. Number 1, mandate surgical coaching in all U.S. surgical training programs. This would be through the ACGME, the accrediting body of all surgical training programs. And what this would allow is introducing our surgical trainees to principles of coaching and self-regulation while there's still an educational infrastructure in place for them during training. This would also address the unreadiness issue that was identified during the study and help educators identify those who are struggling and assist them before they graduate into the workforce. Number 2, utilizing protected time for surgical coaching. The time to coach needs to be protected so that the pairs can meet without having to sacrifice clinical time. Weekly protected time already exists in every training institution in the form of grand rounds. Certain coaches can also have the department buy their time and protect it so that they can coach more surgeons more frequently. Number 3, enlist retired or near retired surgeons as coaches. Retired surgeons are a repository of knowledge, but can see their technical and motor skills decline with age. It's safer to have them out of the operating room as very old ages approach, but give them a new role as a coach. That lets them transition out of performing surgery with dignity, as they are still involved with teaching and improving surgical outcomes. Number 4, incentivize surgical coaching institutionally and nationally. So organizations need to find a way to assign value to coaching, make it count towards promotional activities and financial bonuses, make it count as CME, continuing medical education, make it count for credit towards maintenance of board certification. These are all things that can be done, and other educational activities have gotten value for that. Number 5, normalize surgical coaching at every level to combat stigma. So it is important that that top leadership lead by example and model the behavior for all the faculty and trainees to follow. As a leader, it makes it safe to share vulnerabilities and admit that there's aspects of surgeries that they can still improve on. And that is how you're going to get cultural change and eliminate stigma. Modeling is also a very important aspect of social cognitive theory because learning is done through observation. Lastly, there's recommendations for research. From the study, there are 3 other ideas that came up that would like to be explored in the future. 1, exploring the factors contributing to the feeling of unreadiness in surgical trainees, specifically looking at the impact of surgical culture and stigma as it pertains to preparedness. Number 2, interviewing community non-academic surgeons who have participated in surgical coaching to explore the opinions and attitudes and their experiences with surgical coaching and how it differs from academic surgeons. And lastly, studying coaching in non-surgical but procedural fields such as interventional radiology and really looking at how their culture views and impacts help-seeking behavior in contrast to surgical coaching, surgical culture. That is my presentation. Thank you to my chair and committee, and I look forward to our future discussion.